last presentation of this session, which was to have been done by Dr. Suresh from Kota, but as he had to leave for some urgent matter, Dr. Virendra Agarwal, our President of AIOS, is going to talk about his presentation.
As we all know, Dr. Pandey is a versatile surgeon and a good speaker. I will not be able to do justice to his talk the way he wanted. But what I want to just convey the message. First thing, I must congratulate the ROS team for making this program a very unique program for which the routine problems we face day in, day out, and the bread and butter of the cataract surgery, it is being discussed in detail. And the pediatric surgery is also a requirement for all of us. And what Dr. Pandey wanted to present, there are some innovations and some new things. And the important thing, the pediatric eyes are slightly different, but still they need a similar kind of precision. And as he said, the history was the same. The couching was the first surgery for cataract, and similar was there for the children's. Though we know that these kind of things will not be very good, they are high hypermetropes, and not giving the correction will lead into almost no development of vision. Bilaterality in one way advantage, the other way disadvantage. Unilaterality you need to address faster. The chances of development amblyopia are more often in unilateral cataracts. Bilateral cataracts can be slightly delayed for the treatment, but when both eyes are blind, you can understand how the child is going to behave and what will be the mental development and physical development. I always have one more important thing to say for the pediatric cataracts, that the pediatric cataract or the vision in the pediatric age group is going to decide his future. Because what all he is seeing, he is learning, and his learning is compromised, which many people just can ignore, but we should not ignore, because we are all intelligent people and we know that how the things to be done for the pediatric patients. And I also would like to do a pediatric cataracts myself, particularly for the favor. And there are times when they are not affordable, so you can reduce the charges. Sometimes you can do free, but not always. Those who are affordable, we should charge enough. And the concept of amblyopia, that you require to give time of yourself, that is very, very important. And here comes the innovation what he wanted to present, that there is a swept source OCT handheld and can do a biometry. So major problem in pediatric cataracts is what? We are not able to actually measure the actual power. Though there are different formulas and situations by which we reduce that how much to be done, but accuracy is still not there. So based on the keratometry, you should use handheld keratometer, and then you can do a biometry that will be much more accurate. Otherwise, you can use a contact immersion A scan, but there are doubts that when we do a immersion A scan on the table, should we continue the surgery or should we not continue surgery? But instead of giving 2 GAs, we always do this way, that we do immersion and we do surgery in the same sitting. But if such instruments are available, we will be having a freedom to do it. And the point is very well taken, that MICS with vitrectomy. Vitrectomy, you can do anterior route, you can do a posterior route. Now we know that doing through the pars plana is much more safer, much more effective, and reducing the complications. And it is not as difficult as we were thinking, but you should know where to insert a trocar, because the pediatric eyes, the structure is small, and we need not be 3 millimeter or 3.5 millimeter in adults as we do. Here we limit is 1.5, 2 or 2.5 depending on the age, and averagely it is almost 2 millimeter from the limbus. Go with the trocar, and self-seat trocars are better, and pars plana vitrectomy with the cut rates, which is slightly higher, and suction according to requirement you can do. And as Suresh was saying in the morning, that the posterior capsulotomy and other things can also be done. So you can do a posterior capsulotomy either by handheld, or you can do it by the cutter itself also. The use of radio frequency, plasma blades, femtolasers, and these Zepto kind of lasers can be used for doing a capsulorrhexis, because it's a very big issue to achieve a adequate size and centration in the pediatric cataracts to have capsulotomy anteriorly and posteriorly both ways. And these kind of machines can be of help, but they are having a big cost, non-availability to a routine patients. And as I said in the beginning also, that many patients are not very affordable, so it will be difficult. And there are two important challenges which are there. Visual axis opacification means the PCO, and the myopic shift into the power, which can be controlled, which can be out of control. And sometime I seen, I don't know how much is the experience of the other people, there are many patients who are actually not showing the myopic shift also. So when the power was coming almost 40 diopter, we reduced it, and they are still maintaining the similar kind of hypermetropia, which is very hypermetropia. And we are just waiting for them to have either exchange at a later age or implanting a piggyback lens. But both are going to have much more complications. They are not like adult surgeries in which there can be a more problem. So that is the thing. And there is a different range by which you do a posterior capsulotomy, and by range you do a posterior capsulotomy plus vitrectomy. My choice is that when the patient is very, very cooperative, age can be slightly flexible. But as a rule, routinely, less than 5, definitely it should be done both. And 5 to 8, there are people who can do vitrectomy, they can avoid vitrectomy. After age, in majority of the patients, now we can avoid. But there are literature who says that up to 12, it should be done in every case. Different formulas are there. I will not go into much of the detail because we are not having that much accuracy as we can fight on the formulas. But definitely you can use SRK, SRKT or any kind of formulas and reduce as per your experience. So the flexibility has to be there. And innovation into this is, which is not still in use, is a light adjustable lenses in which you implant a lens and the power can be readjusted after implantation.
Sir, another 2 minutes. The
Okay.
play card has been shown.
Yeah, thank you, sir. So the lens is implanted and a refraction is done, and after refraction you can do a special polymerization by a light, and which will fix the power, which will change the power into the desired power. And then there is another one by which you fix the IO shape and power. So that is way it can be done, and you can achieve the emetropia in almost all. But still it is not commonly used. It was under trial for a long back, but at least for now few years I am not hearing anything about it, that why this is not being under use. And Dr. Pandey is doing a reflection himself. So my request, all the doctors who are here and doing pediatric surgery, do reflection on yourself. You will realize many things. You will do a better reflection than optometrist, and you will see the visual axis is really clear or not clear. And the clarity of visual axis is very, very important. If there is an interference, then you need to do some surgery, some cleaning, or whatever is required should be done. Glasses and contact lenses, preferably if you are leaving aphakia, contact lenses should be used. If you are doing pseudophakia, then glasses are enough. My cutoff now is 6+ months of pediatric age. I implant lenses, but there are sometimes we are waiting for 1 year or 1 year plus. Long-term sequelae are very, very common, and these are the reasons that the pediatric surgery many people are not doing. And the long-term glaucoma, the capsular phimosis, capsular opacification, there can be some changes into the retina which cannot be ignored. So you need to take care of the retina colleague also for retinal examination. And they all are not primary cataracts, means they are not having without diseases. So there are comorbidities which also need to be tackled. And their postoperative management in the medical treatment also is slightly different than adults. They may require some time atropine more often than longer period.
So
and
please sum
steroids.
up. Next session people are
Thank
already
you.
around.
Thank you. And I must invite you for the ROS conference to be held on
3rd, 4th and 5th October in Ajmer.
Ajmer. And next AIOC in Jaipur, that is in 2026.
Ladies and gentlemen, with this...
we all should put efforts that the maximum delegates should be there in both the